Welcome to our first video on congenital phagocyte defects. Let's begin. In this lecture, we will cover chronic granulomatous disease and myeloperoxidase deficiency. Let's start with chronic granulomatous disease and go over its definition, pathophysiology, risk factors, clinical features, diagnosis, and management. Chronic granulomatous disease is a primary immunodeficiency syndrome that is characterized by a defective oxidative burst within phagocytes, such as neutrophils or macrophages. The pathophysiology of this disorder stems from a defect in NADPH oxidase that impairs a series of reactions known as the oxidative burst. The overall result of this impairment is that phagocytes become less capable of killing pathogens, which produces an immunodeficiency and predisposes patients to infections. The X-linked recessive inheritance pattern is the most common inheritance pattern of chronic granulomatous disease, although autosomal recessive inheritance pattern is also possible. Let's utilize this figure to further illustrate the pathophysiology of chronic granulomatous disease. In this figure, we're looking inside a phagocyte as it engulfs a pathogen and delivers it to the lysozyme to be killed in the process known as oxidative burst. There are three key reactions that take place during an oxidative burst. First, oxygen is converted to superoxide by NADPH oxidase. Second, superoxide is converted to hydrogen peroxide by superoxide dismutase. And third, hydrogen peroxide is then converted to bleach, which is then used to destroy pathogens. Patients with chronic granulomatous disease are deficient in NADPH oxidase, which means that their phagocytes struggle to produce hydrogen peroxide, which in turn means that they struggle to generate bleach and kill pathogens. It is this impairment in the oxidative burst that causes an immunodeficiency in these patients and predisposes them to infections. The two primary risk factors for chronic granulomatous disease are male sex and positive family history. This is of course due to the X-linked recessive or autosomal recessive inheritance pattern of this disorder. When it comes to clinical features of this disorder, all patients suffer from recurrent infections with catalase-positive pathogens, or in other words, pathogens that express an enzyme called catalase. Common types of infections include pneumonia, cutaneous abscess, suppurative adenitis, and osteomyelitis, although pretty much any part of the body can get infected in these patients. Common pathogens that infect patients with chronic granulomatous disease include Staphylococcus aureus, Pseudomonas cepacia, Serratia marcescens, Aspergillus species, and Nocardia species. Once again, each of these pathogens contain a catalase enzyme. The other key clinical feature, which is suggested by the name of the disorder, are granulomas that can form almost anywhere in the body, ranging from skin to even visceral organs. These granulomatous form in an attempt to wall off infections that the body can't clear due to an impaired oxidative burst. Let's return to this figure to illustrate why patients with chronic granulomatous disease are particularly susceptible to catalase-positive pathogens. Remember that patients with chronic granulomatous disease struggle to generate hydrogen peroxide due to a deficiency in NADPH oxidase. Despite this defect, phagocytes can still kill most pathogens by making bleach from hydrogen peroxide produced by the engulfed pathogens. However, pathogens that are catalase positive do not have any hydrogen peroxide for phagocytes to use because catalase breaks down all hydrogen peroxide. Hence, catalase positive organisms have an extra layer of defense against the oxidative burst, which allows them to avoid destruction by phagocytes and persist in patients with chronic granulomatous disease. Upon clinical suspicion, the diagnosis of chronic granulomatous disease usually begins with either dihydrorhodamine flow cytometry, which is the gold standard test, or the nitroblue tetrazolium dye test. Under normal circumstances, NADPH oxidase will convert dihydrorhodamine into rhodamine, which in turn will produce plenty of green fluorescence. In patients with a defective NADPH oxidase, on the other hand, dihydrorhodamine will not be converted into rhodamine to the same extent, which will result in diminished green fluorescence. Hence, diminished green fluorescence would be diagnostic of chronic granulomatous disease. When it comes to the nitroblue tetrazolium dye test, under normal circumstances, NADPH oxidase will oxidize the dye and turn it blue. In patients with a defective NADPH oxidase, however, the dye will not be oxidized and will therefore remain colorless. It is important to know how to interpret both of these tests, as examiners often describe the results of these tests on exams. Consider this figure that illustrates two different results on a dihydrorhodamine test. By means of orientation, the y-axis of these graphs correspond to the cell counts, and the x-axis corresponds to the fluorescence intensity. Under normal circumstances, NADPH oxidase will be able to convert dihydrorhodamine to rhodamine, which will yield a lot of green fluorescence. In patients with chronic granulomatous disease, on the other hand, the defective NADPH oxidase will not be able to convert dihydrorhodamine to rhodamine, which means that the extent of green fluorescence of the fluorescence intensity will be diminished. Additional tests that can be used to support the diagnosis of chronic granulomatous disease are a gram stain of phagocytes, which will reveal organisms within phagocytes, and genetic testing, which may reveal the specific genetic mutation that resulted in chronic granulomatous disease. Here's an image depicting phagocytes under a gram stain. Note the multiple little red dots within each phagocyte, which represent gram-negative pathogens that were able to resist destruction by these phagocytes. As far as management of chronic granulomatous disease is concerned, most patients will require lifelong antimicrobial prophylaxis with antibacterials like TMP, SMX, and antifungals like itraconazole. In particularly severe cases, patients may also require interferon gamma therapy, which is a cytokine known to play a key role in macrophage activation and defense against intracellular pathogens. As such, interferon gamma may provide a little boost to the patient's immune systems and help to stave off infections. All that being said, the only potentially curative option is a hematopoietic stem cell transplant. What is the pathophysiology of chronic granulomatous disease? There are many ways to correctly answer this question, which means that there are many ways examiners could phrase the correct response on the test. As such, let's list out the most common ways to describe the pathophysiology of chronic granulomatous disease. First, it can be described as an X-linked recessive defect in NADPH oxidase. Second, it can be described as an impairment in the oxidative burst within phagocytes. Third, it can be described as an impairment in production of superoxide, which is just another way of saying that the oxidative burst isn't working. And fourth, it can be described as an increased susceptibility to catalase-positive organisms. Any one of these definitions or similar sounding definitions would be fair game on the boards. Let's discuss myeloperoxidase deficiency next. We'll go over the definition, pathophysiology, risk factors, clinical features, diagnosis, and management of myeloperoxidase deficiency. Similar to chronic granulomatous disease, myeloperoxidase deficiency is also a primary immunodeficiency syndrome characterized by a defective oxidative burst within phagocytes, such as neutrophils and macrophages. The key difference between chronic granulomatous disease and myeloperoxidase deficiency stems from the pathophysiology of these disorders. While chronic granulomatous disease arises from a defect in the NADPH oxidase, myeloperoxidase deficiency stems from an autosomal recessive mutation in the MPO gene that impairs the function of myeloperoxidase and thus the oxidative burst. Specifically, in cases of myeloperoxidase deficiency, hydrogen peroxide can no longer be converted to bleach to kill pathogens within phagocytes. Let's return to this figure one more time to illustrate the pathophysiology of myeloperoxidase deficiency. Recall that the last step of the oxidative burst occurs when hydrogen peroxide is converted to bleach by myeloperoxidase. In patients with myeloperoxidase deficiency, this reaction cannot take place, bleach cannot be generated, and hence some pathogens will be able to take advantage of this immunodeficiency and persist within the host. The primary risk factor for myeloperoxidase deficiency is a positive family history due to its autosomal recessive inheritance pattern. When it comes to the clinical features, the vast majority of patients with this disorder are completely asymptomatic. That being said, chronic Candida albicans infections have been observed in patients who have diabetes mellitus on top of having myeloperoxidase deficiency. The diagnosis of myeloperoxidase deficiency is usually established with flow cytometry, which assesses for the presence of a functional myeloperoxidase. In some cases, clinicians may also obtain histochemical staining of leukocytes to check for the presence of myeloperoxidase as well. As far as management is concerned, observation is sufficient for most patients. Clinicians should treat infections if they occur, and clinicians should also exercise caution with immunosuppressive therapies in these patients, as it may put them at risk of developing an infection. A common example of immunosuppressive therapy is the use of steroids. What will be the results of nitroblue tetrazolium dye test when performed on cells from patients with myeloperoxidase deficiency and on cells from patients with chronic granulomatous disease? Examiners often mention the results of nitroblue tetrazolium dye test to help students distinguish myeloperoxidase deficiency from chronic granulomatous disease on exams. Recall from our discussion earlier that this test assesses phagocytes for the presence of NADPH oxidase. If a functional NADPH oxidase is present, the dye will turn from colorless to blue. If NADPH oxidase is absent or dysfunctional, on the other hand, the dye will remain colorless. Patients with myeloperoxidase deficiency have a deficiency of myeloperoxidase, not NADPH oxidase. Hence, cells from patients with myeloperoxidase deficiency will convert the dye from colorless to blue. This is in contrast to patients with chronic granulomatous disease who have a deficiency in NADPH oxidase. This means that their cells will not be able to act on the dye and it will remain colorless. Remembering this key difference can help you confidently distinguish these two pathologies on exams. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the congenital phagocyte defects before your exams. Let's conclude this lecture with a multiple-choice question. A 4-year-old boy is brought to the emergency department by his mom for a bad infection on his leg. Mom says the boy sustained a cut on his left thigh yesterday, which turned red, swollen, and painful earlier today. The boy's past medical history is notable for 2 purulent skin infections caused by Staphylococcus aureus and a prior hospitalization for pneumonia caused by Serratia marcescens. The boy's maternal uncle passed away in childhood from a severe Pseudomonas cepacia pneumonia. Blood pressure is 105/80, pulse is 110, temperature is 38.5 Celsius. Height and weight are in the 4th percentile. Physical exam is notable for a 3 by 3 centimeter purulent lesion in the boy's left thigh that is erythematous, indurated, and fluctuant. Initial laboratory evaluation reveals normal leukocyte and platelet counts. Which of the following additional laboratory findings would be most consistent with this patient's clinical presentation? A. Giant granules within leukocytes. B. Absence of CD18 on flow cytometry. C. Increased green fluorescence on dihydrorhodamine flow cytometry. D. No blue discoloration following nitroblue tetrazolium dye test. The correct answer is D. No blue discoloration following nitroblue tetrazolium dye test. This is a case of a 4-year-old boy with history of recurrent cutaneous and pulmonary infections caused by catalase-positive organisms, namely Staphylococcus aureus and Serratia marcescens. Furthermore, his maternal uncle died in childhood after an infection with Pseudomonas cepacia, which is another catalase-positive organism. Because his maternal uncle was affected, the immunodeficiency in question is likely X-linked, and because the culprit organisms are all catalase positive, the most likely underlying diagnosis is chronic granulomatous disease. Recall from this slide that patients with chronic granulomatous disease suffer from recurrent infections caused by catalase-positive pathogens such as Staph aureus, Pseudomonas cepacia, and Serratia marcescens. Next, recall from this slide that most commonly chronic granulomatous disease is inherited in an X-linked recessive pattern. Lastly, recall from this slide that nitroblue tetrazolium dye test will not produce a blue color in patients with chronic granulomatous disease because they have a defective or deficient NADPH oxidase. This is why option D, no blue coloration following nitroblue tetrazolium dye test, is the correct answer. Option A, giant granules within leukocytes, is a finding that is pathognomonic for Chidiac-Higashi syndrome. Patients with Chidiac-Higashi syndrome do not have a particular susceptibility to catalase-positive organisms, and they usually have pancytopenia. Since this patient's leukocyte and platelet counts were normal, Chidiac-Higashi syndrome is an unlikely diagnosis. Option B, absence of CD18 on flow cytometry, is a finding consistent with leukocyte adhesion deficiency. This option is wrong because leukocyte adhesion deficiency is associated with infections that do not have any pus or purulence. Since this patient's lesion was purulent, leukocyte adhesion deficiency is an unlikely diagnosis. Lastly, option C, increased green fluorescence on dihydrorhodamine flow cytometry, is incorrect because patients with chronic granulomatous disease would actually have decreased green fluorescence after a dihydrorhodamine test. This is because a defective NADPH cannot convert dihydrorhodamine into rhodamine, which is the chemical responsible for the observed green fluorescence. This concludes our first lecture on congenital phagocyte defects.